From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello, my name is Don Goff. I'm a professor of psychiatry at NYU Grossman School of Medicine and an associate editor at JAMA. I'll be hosting today's discussion of the article ADHD, Pharmacotherapy, and Mortality in Individuals with ADHD, a Target Trial Emulation. The lead author is Dr. Lin Li of the Department of Medical Epidemiology and Biostatistics at the Karolinska Institute. My guest today is Dr. Francis Levin, who, along with co-authors Marilee Hernandez and John Mariani, wrote an accompanying editorial titled Treating Attention Deficit Hyperactivity Disorder Matters. Dr. Levin is Kennedy Levy Professor of Psychiatry at Columbia University Vagelos School of Physicians and Surgeons and Chief of the Division on Substance Use Disorders. Dr. Levin is an expert on stimulants and the treatment of ADHD. Welcome, Dr. Levin.
Thank you for having me.
Dr. Levin, can you start by telling us why the study of mortality in relation to ADHD medications is important?
Well, I think that it is so important for a number of reasons, but primarily because it just emphasizes the importance of treating ADHD. Unlike other psychiatric conditions, there's often a sense out in the community and even among some physicians that it's overhyped or it's not a big deal. And I think what this article, along with many others that have been done, demonstrate is that this group is at higher risk for having both substantial morbidity as well as mortality. And what's interesting about this article, which was a well-powered, large study, it used EHR data, electronic health records, but using what you said, the emulation trial approach, they looked at a broad range of individuals ranging from 6 to 64 years. I think it was almost 150,000 individuals with ADHD. And they looked at those who received a diagnosis between 2007 over a period of time and completed a thorough neuropsychiatric evaluation, which is somewhat different than what generally goes on for many people in the United States. And then for those diagnosed, they were referred to specialists, and they were able to use this emulation trial to compare those on and those not on medications for ADHD, of which most of the medications used were stimulants. They looked at 3 outcome measures: overall all-cause mortality, the natural cause mortality, and unnatural cause mortality. And natural cause mortality was mostly medical conditions, where unnatural cause mortality were things such as accidental injuries, accidental poisonings, and suicide. And what's so interesting about this paper is that they found that those initiated on treatment had a reduced risk for all-cause mortality and unnatural cause mortality, but not the natural cause mortality. Although, interestingly, this was not the case for women, where there was a reduction in natural cause mortality for those more so on medication than those not. And I think that is an interesting finding as well, because there may be differences that are important, gender differences between men and women.
Great, thank you. Let me just provide a little background for listeners, since probably many are not familiar with target trial emulation. It's increasingly showing up in the literature. So target trial emulation involves designing a protocol as if one were conducting a randomized trial. So you specify entry criteria, outcome measures, duration of follow-up, but most importantly, specifying the time period of observation, typically starting at the time of first diagnosis. And then statistical methods are used to adjust for differences between groups at baseline. So this approach doesn't equal a true randomized trial, but it may improve the validity of results compared to standard methods. For those interested in learning more, Miguel Hernan and colleagues published a guide to target trial emulation in the JAMA Guide to Statistics and Methods column in the December 27, 2022 issue of JAMA. But the statistics won't be a focus of our discussion. We're more interested today in talking about the clinical implications of these findings. But before we go to that, are there limitations to this study and its results that we should be aware of, Dr. Levin?
Yeah, thank you for that question as well. I mean, there are certain limitations that are raised by the authors themselves, which I would agree with. They make sure to point out, as you just said, Don, that this is an observational nature of the trial, the way it's set up. So the results cannot conclusively establish the causal effects of ADHD medication on mortality. There may be unmeasured confounders, such as lifestyle factors or whether or not individuals got concurrent non-pharmacologic treatment or other interventions that may have supported improvement. They did multiple analyses. They make the point, which I made the point also in the editorial, is that you don't really know how well people are adhering to medication. They may have been given the prescription, but whether or not a patient takes the medication is a whole other issue. And then, one of the big things they mention, which I think is an important point, is it's still hard sometimes to distinguish suicides from accidental poisoning, and where they didn't report an association of reduced risk on medication for those for risk for suicide. We don't really know how many of those accidental poisonings may in fact have been suicide attempts in some cases. Other things that I thought were important that, were beyond the scope of the paper. So I don't know if I'd call it a limitation, but something to be thinking about is that, over 90% of the individuals in this study were on stimulant medication. As a clinician, one of the questions I have is, would there have been a difference between amphetamine formulations versus methylphenidate formulations? Also, like I said, adherence, but dosing may really matter. And, there's no description in the study, as well as many other studies that I've looked at in this area, that pay attention to dosing. And dosing may matter tremendously, particularly in substance use populations. And then probably lastly is, I'm sure there are other things we could think about, but one of the other things is the severity of the baseline ADHD symptoms. That may also contribute in various ways in terms of the results, and we don't have that information based on what was presented.
Great, thank you. And underlying what you said, these are observational data, a very sophisticated analytic approach, but nevertheless, we have to be careful about assuming causal relationships. Also, the numbers, although large compared to the literature, are still not that large, so we have to be careful. But in terms of perspective, the authors cite data that premature mortality is about double in people with ADHD compared to the general population. So this really is a very real problem. To the degree that we can draw conclusions from these small numbers and single study observational data, but nevertheless, it looked like there was about a 20% reduction in adjusted mortality rates with the treatment for ADHD. And for accidental poisoning, which includes overdose, it was almost a 50% reduction. So small numbers, we have to be careful about assuming causality, but nevertheless, a potentially substantial effect on what is a pretty serious problem. I'm curious, what do you think the mechanism is, if this is real, in terms of how the medications are decreasing mortality?
Well, that really was a question that I had too when I was looking at the paper and thought about that a lot. And I think inherent, but often not explicitly stated, is the idea that by improving the impulsiveness, the improving executive functioning, being able to make better decisions, not getting in a car and driving in a more risky way. It's interesting when I diagnose or interview patients, particularly adults who are in places that they would be driving, I frequently get a driving history of how many accidents they've had and other kinds of things, because that's often overlooked in a psychiatric interview, but that is very relevant for people who are impulsive, and impulsivity in adults can lead to some dire consequences compared relatively to impulsivity that you would see in children. So it could be that some of it is improvement in the impulsivity that places them in less risky situations, even if they're going to ingest a drug that could be adulterated with other things like fentanyl, that maybe they'd be more cautious or test it before they ingested the drug. And then if you're dealing with a substance use population, a lot of my research over the years has been to determine whether by treating the ADHD that patients are better able to use different psychotherapies or even have a direct agonist effect, which is, a hypothesis not yet proven, but that this idea that treating the ADHD allows them to better utilize clinical treatment for their substance use disorder and therefore reduce their risk of substance use, and in this case, perhaps reduce accidental poisonings or overdoses.
Great, thank you. The authors in their introduction mentioned that, as you noted, that there's some reluctance by some clinicians to prescribe stimulants, because of fears of misuse, but also there's a small literature and, with serious limitations to it that suggests there might be a longer term risk of hypertension and cardiac disease. How concerned are you about that?
Well, again, I have to throw in the caveat that I'm an addiction psychiatrist and I may have a different threshold than general practitioners. But I think not treating is often a problem as well. And I think you have to weigh the risks and benefits. And also you have to know the population you're dealing with. If I'm meeting with an adolescent who is using substances, is not in treatment for a substance use disorder, strictly wants help or treatment for their ADHD, my antenna is going to go up a lot more because that's the high risk group of misuse and diversion of stimulants is that 18 to 24, 25-year age group. On the other hand, if I'm dealing with, I know I'm presenting extremes here, but if I'm dealing with somebody who's in their late 40s, have never been diagnosed with ADHD, they're in substance use treatment, and I'm the one recognizing that they have ADHD and feel they would benefit from ADHD medication, I would potentially use a long-acting stimulant for that person and monitor them closely. So I think you have to know who you're dealing with. There's been a lot of concern, rightfully so, that these medications can be misused and diverted. One of the things I said in the editorial is that, the rates of prescription stimulant use disorder is actually higher by the National Survey on Drug Use and Health than either cocaine use disorder or heroin use disorder. But, it's still not a large group, and we do not yet, luckily, have an epidemic of stimulant misuse or abuse the same way we have with the opiate epidemic with prescription opioids. But we should be cautious. And I think, part of being a good clinician is evaluating each patient and making a decision based on each patient. There's an interesting study that Dr. Cast and Tim Willens published on individuals coming for treatment for an active substance use disorder. And frankly, the patients who were actively being treated for their ADHD, most again who were on stimulants, they were more likely to stay in treatment. And what we know from the substance use literature is that if you keep people in treatment, they're more likely to do better. So, I think there is a growing literature that it can be done carefully with certain populations, but you need to weigh the risks and benefits. In terms of the hypertension, in that recent article that you mentioned, there was a meta-analysis showing that in, again, registry data that individuals who are on stimulant medication have a greater likelihood of having hypertension or atherosclerosis. Again, the authors emphasize, as well as I would, is that you have to weigh the risks and benefits. Usually it's a small rise in blood pressure. It usually can be managed clinically. Often if people are concerned, they can consult with a cardiologist. But other serious things like arrhythmias and I believe myocardial infarction were not found elevated in that review. But like every decision we make on any medication we use in psychiatry or in medicine is weighing the risks and benefits.
Thank you. This has been Dr. Don Goff for the JAMA Network. I'd like to thank Dr. Levin for joining me to discuss the potential impact of ADHD medications on mortality. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.